Okay, this is chapter 34, mature lymphoid neoplasms. So we'll go over the genetic abnormalities that we will see with lymphoid neoplasms, how we classify them by looking at the cells, what laboratory medicine, clinical medicine we'll use to make a diagnosis as to what it is and how we evaluate that diagnosis, and then all the different leukemias, non-Hodgkin lymphoma, and the plasma cell neoplasms. So mature lymphoid neoplasms. So this is not the acute leukemias. These are mature lymphs. They have varying clinical presentations. They take on a lot of different things. So the disease states are how we identify the cells we see in the blood, the bone marrow, the lymph nodes. So that brings it down to the types of disorders we see with lymphoproliferative. It's either leukemias or lymphomas. Leukemias means it's in the blood or the bone marrow. Lymphomas means it's in the lymphatic system. So the genetic abnormalities that we see is relation to the B cells and the T cell lymphocytes. If you look on table 34.1, you will see the chromosome translocations, insertions, deletions, inversions, things that were there for them. And you'll see, this will tell us what genes have been misplaced or moved or mutated, which then allows the genes to cause a different expression now. Because of this altered expression, that's when we start getting the leukemias and lymphomas, maybe. So there are some examples of the ones that we'll be talking about. So the morphology isn't always accurate because there's a lot that goes into trying to identify these cells because we need to look at the mutations, the immunophenotyping using flow cytometry, the BT and natural killer cells, lymphatics, and how they mature. And then with all that information, that's where the WHO does the 2022 classifications. So to make a diagnosis between the clinical and laboratory medicine, we have to look at the clinical signs and symptoms, which unfortunately we can't see all the time. So the patient comes to us for blood work. But usually the patient will complain of being weight loss, night sweats, lymph glands enlarged, feeling full, spleens enlarged, that kind of stuff. But sometimes they can be asymptomatic. Absolutely nothing. If you look at table 34.2, table 34.2 will actually have in there all the different types of immunophenotyping that we could possibly see, which gives us an idea to the diagnosis as to what it is. But the basic thing that's done is a CBC. We look to see if the lymphocytes are increased and what's the morphology of the limbs. Of course, the flow cytometry, which we talked about, and then we have to do protein electrophoresis, which we'll explain in a little bit here, immunofixation, a direct antiglobulin test, and a comprehensive metabolic panel. And you'll be doing all those stuff eventually in labs. And then the biopsies and FISH technology, depending on the tumors, the biopsies they've gotten, and then imaging studies to determine what tumor involvement there may be. You look at box 34.2, which I'm sorry I can't put all this stuff in here, but some of them are so big. But box 34.2 is a 2022 WHO classification of mature lymphoid neoplasms, and there's a lot. So we're not going to cover every single one, but we're going to try to stick with the ones that are most important. And you'll actually see them highlighted in red most of the time. So all of the staging that's done is usually set up by what's called the Ann Arbor method. And what they do is they look at the different stages, like stage 1, 2, 3, and 4. And table 34.3 will actually show you that. But that's how we can determine, is there bone involvement, is there organ involvement, so forth and so on. So that's the stages 1, 2, 3, and 4 that you hear. And then the ABCs that come with it. And from all that data, we can give a prognosis as to what's going on with the patient. This thing's got a mind of its own. So the first leukemia that we deal with is CLL or SLL, chronic lymphocytic leukemia or small lymphocytic lymphoma. So the leukemia means it's in the bloodstream now. The lymphoma means it's in the lymphoid organs, just in the tumors. So usually this is the most common CLL, most common one that we see. It's usually seen in older adults. Usually they're greater than 65. They have no symptoms. It's just routine blood work. We find it. So if you look at the picture on the top right, you can see the morphology, the B lymphs. I mean, it's just normal looking lymphs. They're just compact. Just there's a lot of them. The chromosomes is pretty packed. They have that soccer ball appearance is what they call. The bottom picture is looking at lymphs because, they're malignant, they're cancerous, or leukemia. They're fragile, so when you make a smear, it smushes them. So we call those smudge cells. So to make the diagnosis using flow, the B cell markers, CD19, 20, and 23, will be indicative of CLL. Sometimes they'll have surface immunoglobulins, surface antibodies on them. The bone marrow can also identify it using FISH technology. So the CBC will show a white count is usually greater than 25,000. The anemia is normochromic, normocytic, and there's thrombocytopenia. So the staging prognosis they use for this particular one is the Ray-Benet system. Again, it's looking for the bone marrow, the organ involvement, everything. The mutations that we could possibly see, and I have a few of them listed there. Any risk factors? Do they have some kind of immunodeficiency? Do they have autoimmunity? But they're all basically treated with some alkylating chemo reagent or an anti-CD20 monoclonal antibody, which is rituximab, which is a common drug that's used. Another leukemia, which is extremely rare, but is still mentioned here, is the monoclonal B-cell lymphocytosis. So you're probably wondering, what does monoclonal mean? What happens in this particular case is the B-cell, one individual B-cell goes nuts, and then it mass produces itself. That's monoclonal. If it's more than one type of B-cell, then it's polyclonal. So this is monoclonal. So it's very rare. No symptoms, but it looks like CLL on the smear. But you got to do a biopsy to identify it. So a T cell, prolymphocytic leukemia that we run across, could be CLL or SLL progressing to getting worse. But these cells that you can see from the picture are larger. They have, more cytoplasm, and they got this like little bumps on the cytoplasm, what they call that cytoplasmic blebbing. Also, the nucleus has got little nucleoli in there. You can see them, and this CD7 marker. So the treatment for this particular one is anti-CD52 monoclonal antibody, but it doesn't work that well because T cells are nasty. Next leukemia is hairy cell leukemia. Just look at the cells. They have like hairy-like projections, hence the name. It's a B cell, and it's usually somewhat greater, 50 years of age. Usually on the CBC analyzers, they'll classify these as monos. That's why it's important you do that smear to look at it. So they have a lot of cytoplasm. Again, those hair-like projections. They're usually round. They can be oval shaped, can be a kidney bean shape. If they did do a bone marrow, usually the bone marrow is called a dry tap. In other words, when they went to pull, they get the aspirate out, there's nothing there. It's just there's so much stuff in the bone marrow, we can't get the liquid out now. They do a special stain called the TRAP stain, which is tartrate-resistant acid phosphatase. That is a diagnostic stain that's still used to this day. CD markers we see, it's a normal B cell, like 19, 20, 22, 25. But the 11C, and particularly the 103, is a very diagnostic for hairy cell. And the only treatment you can do is to remove the spleen so it doesn't eat all the cells. So we keep the counts where they need to be. The next one is the large granular lymphocytic leukemia, LGL. Here we have the cytoplasm. It's pale blue, a whole bunch of it. It has now eosinophilic granules, so do not confuse this with myelocytic series because it's blue cytoplasm. nucleus, is pretty routine for a lymphocyte. It's rare. The patients use asymptomatic. They don't even know they got it. The CD markers show CD2, 3, 8, and 57. And there is a natural killer cell variant, NK variant. I apologize, this thing keeps jumping. So treatment is blood transfusions, giving them platelets, whatever. Just treat the symptoms they got. Okay, now we get into non-Hodgkin lymphoma, so it's a lymphatic area now. So what you basically do for these is you need a biopsy because it's, in some organ or the lymphatic system. That's usually where it is. So the first one is the adult T-cell leukemia lymphoma, so it's both. So now it's actually spilling to the blood, and that's what that picture is. It's seen because they have HTLV1, which is human T lymphotrophic virus 1, which is seen in Japan, South Pacific, and the Caribbean. So the flow shows T-cell markers, which are CD2, 3, 4, 5, and 25, just because it is a type of lymphoma. The lymphs, you can see that one in the top middle, very lobulated, looks like petals of a flower is what they call it, or a clover. It's big. There's two other normal looking lymphs in there. So the treatment, isn't that great because it's very aggressive. They give AZT to this. The next one is Burkitt's lymphoma, and this is an aggressive B cell. They have huge tumor growth. It's very fast. There's different subtypes of it: endemic, sporadic, and immunodeficient. The most common is seen in children in Africa. It's more endemic. In the United States, it's more the abdominal due to immunodeficiency, which could be caused by an HIV. But what's scary is it's Epstein-Barr virus has been seen with people that have this. So in the clinical phase, you can see the pictures there. It's characteristic morphology. It's all lymphs that have tons of vacuoles in them, very starry sky, blue, deep basophilic cytoplasm to it. I mean, you can see them as very characteristic. It's a CD10 markers. But fortunately, it's very responsive to chemo, and it is curable until you see this picture. This is Burkitt's lymphoma seen in children in Africa. It's a nasopharyngeal thing. Of course, this has really progressed extremely far, but definitely not good. The next one is follicular lymphoma. As you can see from these cells are smaller. The chromatin is very condensed. Not much cytoplasm there. But if you look at the nucleus, it's sort of folded over like dough folds over, and they call that nuclear clefting. So the markers are 19, 20, 22, and 45. So again, it's a B cell kind of thing. So they do treat them with anti-CD20 monoclonal antibodies. The next NHL is mantle cell lymphoma. That's 6% of all the NHLs out there. It's usually men greater than 60 years of age. It's pretty aggressive. It has lymphadenopathy, and it's usually seen in the GI tract. 75% of them, it will go into the blood and bone marrow. That's why it's important, that we constantly do CBCs to check on these people. But you can see there's many cell types. I mean, this is not a small one, small to mediums, but they can be large, like the picture we're looking at, pretty pleomorphic. In other words, all kinds of shapes and sizes. I mean, these are pretty immature looking. This looks like a blast. So that's where you got to be very careful, get a pathologist to review a lot of this. So the treatment on these, which is watch and wait, which seems odd, but that's what they do. And then it's combination chemo, stem cell transplants, or CAR T cell therapy, which we'll talk about a little bit later. The next one is diffuse large B-cell lymphoma. This is the most common. You can see how big they are. I mean, they are huge, large, round, irregular shaped nucleus. They do have nucleoli in them, just weird looking. and they can transform into the other lymphomas. And it's usually seen in elderly individuals. But it can involve the bone marrow. Usually it's the lymph nodes in the GI tract is where they end up finding it. It is very aggressive, but it's curable. Most of these B cells now are considered pretty curable. The next one is marginal zone lymphoma, and we have 3 of those listed for the marginal zone. And where it's coming from is in the lymph node. This is the margin of that zone that's margin in the lymph node. That's where we're talking about here. So one of them is a splenic area, and one is a lymph node area, and one is the MALT, which is the mucosal associated lymphoid tissue, like in the GI tract. That is the most common, and that's what this picture is. It's a B cell, and it's usually associated with Helicobacter pylori infection in the GI tract, which causes gastritis. So that's why it's important all these biopsies and stuff it's done. The splenic marginal zone lymphoma, very rare. They look like CLL cells, again, an older person. The nodal marginal zone lymphoma, again, not that common, still same age group, but this one is usually associated with hepatitis C virus. The next NHL is mycosis fungoides and Sézary syndrome. It is the most common cutaneous T-cell lymphoma out there, again, seen in elderly patients. So it is a skin disorder. They get red, scaly rashes on their body. The CD4s are positive, and you can see from the cells there, they don't have a lot of cytoplasm, so a scant amount of cytoplasm. The nucleus is pretty folded. You can see where it's sort of dark, but you can see where it's like folded over itself. They call that cerebriform. So the chromatin has different appearances to it. So the treatment they use for this particular one is topical steroids and phototherapy, like a tanning bed sort of. And they just keep checking the progression on it. So these rashes can be all over the body, trunk, back, arms, legs, everywhere. The next and last NHL is anaplastic large cell lymphoma. Again, it's a T cell. You can see in the top picture there on the left. Very large, very pleomorphic, really oddball shapes to it. It's a CD30. I mean, the other two ain't that great either, but combination chemotherapy, there is a 5-year survival and 90% chance of that, so that's good. Peripheral T-cell lymphoma, in other words, this is where we're going to put all the rest of them now. You can see it's a very large cell. It's negative for CD7 and CD5, and again, combo chemotherapy is given. So you can see looking at lymphs is not an easy thing. They take on all kinds of shapes, so anything questionable, you need to get a pathologist to review it. Okay, now switching things here to Hodgkin lymphoma. This is all based on lymph nodes usually. And it usually happens to people, in their 30s and then goes away and comes again when they're greater than 50. But usually the lymph nodes are enlarged and there's no pain with it. And what's unusual when they do the biopsy is that they see these Reed-Sternberg cells, and they call them the owl eye-like cells. I mean, you can see the picture up there in the top right compared to a regular lymph. It's only seen in the lymph node. You will not see this in the blood. They're positive for CD30 and CD15. But there's 4 different types of Hodgkin lymphoma. There's nodular sclerosis, mixed cellularity, lymphocyte rich, and lymphocyte depleted. It depends on what you see, but this is more of a pathology because we don't see in the blood really. The treatment to that is it's 85% cure rate and it's combination chemotherapy again. Okay, now we're going to the plasma cell, neoplasms, and remember plasma cells are actually transformed B cells. In other words, they've been antigenically stimulated. They've been asked to change to make antibodies now. And antibodies are called immunoglobulins. And they're located in the gamma region of all the proteins, which I'll show you a picture here in a little bit. So what will happen is the plasma cells get malignant, hence neoplasm. And they just fill the bone marrow up. So that means hematopoiesis, formation cells aren't there. And they just secrete gobs and gobs amount of immunoglobulins, antibodies. So one of them is called monoclonal gammopathy of undetermined significance. In other words, this is the benign side of it. It's not malignant yet, but it's going to go there. The only thing we see is the total proteins elevated in their blood work. So when we look at the malignant side of the B lymphocyte and plasma cell, it's multiple myeloma. So with multiple myeloma, we have bone involvement. So in other words, the antibodies, the immunoglobulins they're producing are IgG, immunoglobulin G, which I'll talk about here in a second, or IgA. And because there's, because they're a protein, and because there's so much protein, the protein sort of like covers over the red cells. So they're supposed to normally repel each other and stay some distance apart. Well, they can't now because the protein's like taking that charge away. So they stick to each other. And that's why you get that rouleau, like, coins or dishes, whatever you want to call it. And then in the bone marrow, we see plasma cells. So it's not that, very rare to see the plasma cells in the peripheral blood. But the amount of proteins they produce, will actually go through the kidneys, and we will see those as the light chains of antibodies, and we call those bench chains proteins. So in multiple myeloma, it is a common plasma cell dyscrasia. And you can see from that picture, what will happen is the osteoclasts, the cells that eat the bone, eat a whole bunch of bone. So we get all those little round black things, circles, and that's the lesion. So it's eating bone, osteolytic. And that causes a tremendous amount of pain. That's usually how the patient comes to the hospital with bone pain. And because of all the protein that's made by the plasma cells, the kidneys can't handle it. There's just too much protein going through and just tears apart the glomerulus. So now everything goes through the kidneys and it can't do its job. So there's renal failure. Other things we look at is we electrically separate the proteins out. And that's called protein electrophoresis. Okay, and I'll show you a picture here in a second. But there's usually a lot in the gamma region, which is where the immunoglobulins are. So you can see the percentages. I mean, they're supposed to be single digits, and now they're extremely high. So the bone marrow has a lot of plasma cells. Again, not in the bloodstream. So we get anemia that's normochromic, normocytic. Again, that rouleau that we were talking about. The calcium is very elevated because the osteolytic lesions that we're actually seeing. Now with those, the calcium just climbs, because it's eating the bone. The serum creatinine is elevated just because the kidneys can't do what they're supposed to be doing. And the clinical course all depends on how much plasma cells are there, how much osteolytic lesions. So if you catch it early, it has a pretty good survival rate. But if it becomes advanced, then no, you won't. The survival rate is less than 2 years. So here's a picture of the bone marrow on the right and peripheral blood on the left, which is very rare to see that. So you can see the plasma cells. They're very eccentric nucleus, dark blue cytoplasm. This one's just loaded with it. So in multiple myeloma, like I said, the peripheral smear, you shouldn't see plasma cells. So what's happening is the plasma cells are in the bone marrow and they're just taking up a lot of space, as you can see from that picture. So they get pancytopenia. In other words, everything's decreased. And now because there's so many cells, it's packed the marrow and it's very painful now. So with these plasma cells producing antibodies, so there's a lot of immunoglobulins, these antibodies, and they are in different types of protein chains, heavy and light chains. And usually because there's one B cloned, so that's a monoclonal, and because it's abnormal, that's called a monoclonal gammopathy. So you can see the heavy chains are IgG, immunoglobulin G, IgA, IgD, IgE, and IgM. We'll talk about those in great detail when you get to immunology. The light chains are the kappa and lambda. Again, it's the structure of the antibody. So the most common one is IgG. So usually with all this amount extra protein being made, it makes the liquid very viscous. So it can't get around. It's like syrup. It's just hard for it to move. And again, the Bench-Jones proteins, these light chains, are going into the kidney, tearing it up, so it actually is leaking through the kidney, so we see it in the urine. So this is the protein electrophoresis. So the bottom picture, what we've done is that we've, made little slits in this agar, looks like jello, and you put the serum in it, and then you apply electrical current to it. And then once it's done, you stop the electrical current, then you apply a stain, and the stain will make, will attach to where the protein is, hence the blue color. So the SP is a serum protein. So you can see the very bottom one, that's albumin. It's the greatest content. And then and from the picture at the top, you can see there's albumin, alpha 1, alpha 2, beta, and then the gamma region. Some Greek letters. So the gamma region is where the immunoglobulins are. All right, so if you looked at the bottom picture again, you can see it doesn't have the IG on it, but the G is elevated. So that's showing from the picture above the monoclonal spike. So the picture above the actual electrophoresis agar, that's actually a graphic presentation of what we see in that bottom picture. So the IgG is elevated, so they call that a monoclonal spike. There is no A, no M, but there is some kappa there, but we don't see that on the protein electrophoresis. It tells us what light chains are there. All right, so you can see some basic results on the left-hand side. So that sort of indicates to us, what's going on. And you will be doing protein electrophoresis and the immunofixation, which you see in that bottom picture. So then you get the plasma cell leukemia. Now is when we see the plasma cells in the blood. So here we have no rouleau now, because they're not making the protein, not like they were before, okay? It's just light chain, just the kappa and lambda stuff now. So we're going to see a lot of plasma cells in there, which I'll show you a picture in a second. So the white count will be sort of high because of the plasma cells, but the platelets and the red cells will be decreased. So the patient still has renal failure because of all that protein that's going on, but the spleen and the liver is also enlarged. Now, this type of leukemia is very aggressive and has a very short survival. So here's a picture of the plasma cells. You can see the eccentric, in other words, the nucleus stuck to one side, very dark blue cytoplasm. There's a little bit of a pale area right next to the nucleus. And we'll be seeing those when we get into the lab. Waldenström's macroglobulinemia, instead of IgG, it is now IgM, and IgM is 5 times the size of IgG, which you'll learn in immunology. But now we have like molasses for our serum, so it's super, super viscous, and because of that, the heart can't pump it, so that's why we have CHF, congestive heart failure. They get neural problems, so they get confusion. The platelets get covered up, so they can't work. So now we have mucosal bleeding, and they could possibly go into a coma. If the blood sits, it actually, crystallizes almost out, called cryoglobulins. So the way we treat these patients is we actually do plasmapheresis. In other words, you hook them up to this machine, it takes their blood out, gives them their red cells back, then we give albumin or plasma back, but not their plasma. They're taking the plasma out. It only works temporarily because it's still, you're not taking care of the problem. So they can give chemotherapy, and it's usually a monoclonal antibody for CD38, so it's an anti-CD38 treatment. And other things that we see is cold agglutinin disease. In other words, their cells, when they sit at room temperature, sort of look like they're clot. Remember, because of these cryoglobulins now. I mean, it's really weird. And another therapy is called CAR T therapy. It's chimeric antigen receptor T cell therapy. We can take the T cells out, program them to destroy the bad stuff, and reinfuse them in the patient. It's pretty cool stuff. So that was mature lymphoid neoplasm. So you make sure you know the difference between leukemia and lymphoma. Just some chromosomal translocations and all the stuff we use to diagnose it and what the morphology looks like. If you have any questions, please let me know.